Are you guys able to see my screen?
Yes, we are.
Perfect. Yeah, the slides will be sent out tonight, or you'll get them first thing tomorrow morning, depending on when it goes through. I know now that it's September and pumpkin spice is out at Starbucks, I thought it was very fitting. Okay, we'll give it a couple more minutes because I want to start relatively on time just because I have a lot I want to get through and I really want to get to questions as well. Okay, does anyone have any questions before we get started? Okay, so I'm gonna get started. For those of you who have not met me, I'm Olivia. I'm one of your anatomy TAs, and I'll also be helping out in neuro. So today I'm gonna be covering a lot of blood supply. We're gonna go over some radiographs of fractures of the arm, and then just some practice questions just to kind of combine everything between blood supply, brachial plexus, muscles, and how all of that works into play, just because that's one of the most high yield things. And not only will it help you in lab, but it's going to help you with your brain as well. And those are my two dogs, Jordy and Harper. Okay, so starting with the blood supply, we have the subclavian artery. And so basically, I draw these line diagrams, and you can take a screenshot now or you can practice drawing it out on your own. But practice drawing this out. I'm a big fan of like these line diagrams just because it really helps me keep track of everything, and you can stack one on top of the other. So, kind of to make sense of this crazy looking drawing is we're going to start here off of the aorta. And even though you guys haven't learned this yet, you're going to next unit, but you have the subclavian that comes off of the aorta, and you have a right subclavian. You also have the left subclavian. So your left one will come directly off of the aorta, and then your right one will come off of the brachiocephalic trunk, which is more of a later problem, but just to give context as to where the heck this is coming from. And there's various branches. So the first branch that you're going to find off of the subclavian is your vertebral artery. Now, your vertebral artery is going to go through those transverse foramen beginning at C6. So that's a good tidbit to keep in mind because from there, it's going to go straight up to the brain. Then I go to number two, and this is the internal thoracic artery. I crossed it off right now because this is a later U problem, but I want to just include everything for completeness sake. You'll learn about this next unit. The third branch you find off of the subclavian is the thyrocervical trunk. And so, since it's a trunk, it means it's going to give rise to more than one artery. So, one of those being suprascapular artery, another one being transverse cervical artery, another one being inferior thyroid. Again, I cross it off because this is a January U problem. But when we think about what's coming off of the thyrocervical trunk, the suprascapular artery, now, this is where you can really stack on and add, like, be really able to test yourself. Is if it were me, I would be like, okay, what muscles is supplied by the suprascapular artery? And then I would say it's the supraspinatus and infraspinatus. From there, I can be like, okay, well, what's the nerve that supplies those two muscles? And then I could go the suprascapular nerve. So that's kind of a way of just being able to like add everything on one onto the other. Then you have their transverse cervical artery. And if you remember, this helps supply the trapezius, and that's innervated by cranial nerve 11. Then our fourth branch off the subclavian is the costocervical trunk. And since it's a trunk, it gives off two arteries, the deep cervical artery and the supreme intercostal artery. This is something to worry about later, but again, like just know that it's coming off the subclavian. Like you're not going to be tested necessarily on like this branch here, inferior thyroid, or the costocervical trunk necessarily right now, but it'll help that you at least recognize that it does come from the subclavian. Then our last one, we have the dorsal scapular artery. And this one's super variable. So it can come off on its own. It can come off the thyrocervical trunk. It's very variable in every single body. So that's why I kind of put that. Um, it depends. It can be on its own. It can be part of the thyrocervical trunk. And then we know that the subclavian will then continue into that axillary artery, which I'll go over next. But is there any questions on the subclavian right now? Okay. And then just for completeness sake, the dorsal scapular artery, we know those are going to supply your rhomboids, both minor and major, and levator scapulae. And then it's the dorsal scapular nerve that does those. Now, when we think about the axillary artery, so our subclavian turns into the axillary artery, and you're going to hopefully start to see this in lab this week. And we know that there's three parts, and it's broken up by its relationship to the pectoralis minor. So part one is your superior thoracic artery, which you'll find medial to pec minor. This artery, you don't really need to worry about what it does right now because you're not really going to learn it this unit. It's more next unit. So again, it's one of those things just to recognize. And the cool thing about the axillary artery is that each part gives like the same number. So part one gives off one artery. Part two gives off two big arteries. Part three gives off big three arteries. And this is something that I always just helped me just to kind of remember like, okay, am I missing anything? I know I should have two here in part two. And in part two of the axillary artery, you're going to have, it's going to be posterior or deep to pec minor. Your first one is the thoracoacromial branch, and it gives off four little branches, one going to the clavicular, two going to the acromion, three to the deltoid, four to the pectoral, like your pectoral muscles, so both major and minor. And I remember this by the mnemonic, cadavers are dead people, so CADP, and that's part of that thoracoacromial. Then you're going to have the lateral thoracic artery. And then just to trigger your memory, this is supplying your serratus anterior. That's innervated by your long thoracic nerve. So remember, if you have an injury to your serratus anterior, your long thoracic nerve, that's how you end up with that winged scapula. Now, when we go to part three, this is going to be inferior to your pec minor, and you're going to have three big branches. So one being subscapular, two being your anterior and posterior circumflex humeral arteries. Now, backtracking a little bit to subscapular artery, this is going to help supply your subscapularis muscle, which is innervated by both your upper and lower subscapular nerves. And subscapular artery is going to give off two branches. One being your thoracodorsal, more medial, which is going to go to your latissimus dorsi, which is innervated by your thoracodorsal nerve. And your other branch is going to be a circumflex scapular, which is going to go more lateral because it's going to wind around and kind of go towards the back of the scapula. And this is so important in that scapular anastomosis when you think about subscapular, circumflex scapular, dorsal scapular from your subclavian, and your suprascapular also from your subclavian. So think about if you have an injury to your subscapular artery and you're not getting blood supply to that area, well, what can take over is your subclavian with the dorsal scapular, and suprascapular can help out. So you're not losing total blood supply there and it's getting all ischemic. So that's really important is knowing, so, okay, my axillary artery is more distal. So if I have a cut here, it's not going to affect what's already been giving off above. And then the last two branches of the axillary is going to be your anterior and posterior circumflex humeral arteries. And these kind of run really close to each other in lab. Typically, the anterior one's a little bit thicker than the posterior one. And it's variable in every body, but that posterior circumflex humeral, remember that runs in the quadrangular space with that axillary nerve. So just something to keep in mind there. Okay. Any questions on the axillary artery?
I have a quick question just to clarify for the thoracomial. Does that say deltoid at the bottom?
Yes, it does. Sorry, my
Oh,
handwriting can get a little messy.
no, you're all good. Thank you.
Yep. Okay. Any questions? Any other questions? Okay, I'm going to continue. So this next one is a little overwhelming, but this was one of our, when we had objective sheets back in the day, this was one of our objectives for the exam is knowing the elbow anastomosis that takes place around the lateral epicondyle. So just backtracking before you get super overwhelmed, and this is something like as you can go over on your own too later, but just to kind of briefly introduce this to you is like we want these anastomoses because if one part is failing, we want another part of the body to take over because if it didn't, it would be bad. So remember, we have the subclavian artery. It's going to turn into the axillary artery. And then our axillary artery becomes this brachial artery. And so just follow the red for right now, but we have the brachial artery. So that's what's going to go through that cubital fossa area of your forearm. And eventually it's going to split into a radial artery that's more lateral and an ulnar artery that's more medial. And that radial artery is kind of where when you feel a pulse on someone's like wrist, that's what you're typically feeling for. And it's near that anatomic snuff box. Then just going back up, we know that our brachial artery is going to give off this profunda brachii artery, and this runs with the radial nerve in that triangular interval, and it's going to help supply those extensor muscles. So think any extensors of the forearm, we're thinking like triceps, all the extensors. So then off of the brachial artery, you have these collateral branches, and collateral meaning like they're assisting, they help out, and these are what anastomose off of various branches from the ulnar artery or the common interosseous artery, which comes off the ulnar. So all of these lines are kind of dictating like where it comes off. So like the radial recurrence coming from the radial artery, the anterior ulnar recurrent and posterior ulnar recurrent are coming off the ulnar artery. So some of these are just extra random branches, but I just included it for completeness sake. And so coming back up, the brachial artery will give off this superior ulnar collateral, and this is going to anastomose with the posterior ulnar recurrent artery from here, from the ulnar artery. The inferior ulnar collateral is going to anastomose, that's what the A means, it's anastomosing, with the anterior ulnar recurrent artery. So they both have ulnar in their name. They're going to anastomose with these two branches off the ulnar artery. Then you have the radial artery, and it's just going to give off this branch, radial recurrent artery. And you can see it right here as well on this side if you like this way a little bit better. So it's coming in this lateral epicondyle area, because this is lateral, and then this would be medial. Then from your profunda brachii, that's going to split into two branches. You're going to have a medial collateral artery branch and a radial collateral artery. And anytime you think radial, think that's going to be your lateral side. So your radial collateral is going to anastomose with that radial recurrent. So here, and you can see it here as well. So this is the radial collateral branch from the profundi brachii. And then this is the radial recurrent coming off of this radial artery, and it's anastomosing this area as well. Then you have the medial collateral artery, and that's going to anastomose with the radial interosseous artery. And that's down here. So you have these common interosseous arteries that comes off the ulnar artery, and that breaks into three, which is going to be the anterior, posterior, and radial. So the radial interosseous is the one that's going to anastomose with that medial collateral. I know this is definitely super overwhelming and it's just something to sit through, but I wanted just to walk through like what this looks like. And then well, I don't think I came up with this mnemonic, someone else definitely did. But it's sim pair. So it matches what it goes with. So the S and the P go together. So superior ulnar collateral goes with the posterior ulnar recurrent. The inferior ulnar collateral goes with the anterior ulnar recurrent. Middle collateral goes with the interosseous recurrent, and then the radial collateral goes with the radial recurrent. So once you kind of get this formatting of what this looks like down, this is a great mnemonic just to help you remember, okay, what's going with what. Any questions on this? Because I know this is a lot, like a little overwhelming on how it looks, but I promise, like once you sit with it and practice drawing it out yourself, it's not as scary.
Sorry, can you repeat what the Nanomic stands for again?
Yeah, so it's sim pair. So the S and the P are aligned together. So it's like the top and the bottom in line are the ones that go together. So the S, superior ulnar collateral, will anastomose with the posterior ulnar recurrent artery. So S and P. Then I and A, inferior ulnar collateral, will go with the anterior ulnar recurrent. And then M and I, medial collateral artery and the interosseous recurrent artery. And then R and R for radial collateral artery and radial recurrent artery will anastomose together. Does that help?
Yeah, thank you.
You're welcome. Okay. Any questions on this? Are these like line diagrams helpful for you guys in visualizing it?
Yeah, I find it really helpful.
Okay, great. All right. And then this I just wanted to include. So when you go into lab, like I know it seems like, oh, the axillary artery, three parts, it's a big artery. It's really not. It's actually pretty small. So a lot of the branches you don't really necessarily get to see. So I wanted to kind of include this like cadaveric picture of like what it theoretically will look like. Unfortunately, our dissections probably won't look like this. But remember the thoracochromial, which will give off the cadavers are dead people branches. So your clavicular, your acromion, your deltoid, your pectoral branches. This is your lateral thoracic, which would go to your serratus anterior. You have an anterior and posterior circumflex humeral. Now, on this one, the posterior one does look a little bit thicker. Typically, the anterior one has in the past in our bodies, but anterior is usually going to go first. And if you're ever look, my biggest advice is always look where it's going. So anterior is going to go in front and anterior of the humerus versus posterior is going to go behind. And if you're looking at the back, you know you're going to find that posterior circumflex humeral artery in that quadrangular space. Then you have the subscapular artery, which is going to give off the circumflex scapular. And then if it's continuing straight down, that's going to be your thoracodorsal, going to your latissimus dorsi. And then here's just some more. I know you guys did brachial plexus a lot last week with Tyler, and then Kate did the workshop today, but you should be seeing this in lab. So the biggest thing with the brachial plexus in lab is you look for this M, and then the musculocutaneous nerve, which is going to pierce the coracobrachialis. Your median nerve is like the middle of the M, and then the most medial is the ulnar nerve. Right underneath, there's like it's arteries are big, they have like different layers to them, is typically your axillary artery, and then your axillary nerve and radial nerve is deep to this as well, deep to the M. So just to kind of visualize this, because hopefully you're going to be seeing this in lab, and just a reminder to keep reviewing the brachial plexus because it's so important. Okay, now we're going to get into some questions. So what I'll do is I'll give you guys like a minute and a half probably to get an answer ready. Don't put them in the chat yet, just because I want everyone to have time to do the question, and then we'll go over it. So go ahead and read. Okay, feel free to put your answer in the chat or on mute yourself if you want to answer out loud. Awesome. Yeah, you guys got it. So, yep, it's your median cubital vein. So, venous system's important, and I did want to touch briefly on it. But yes, your median cubital vein will connect the cephalic and the basilic vein over the cubital fossa. Remember, your cephalic vein's typically going to be more lateral, and you're going to be able to find it really well in this deltopectoral groove. So, it's a small groove between your deltoid and your pectoral muscles, so major and minor, and it sits like super nice in there. More medially, if you're going to see a vein, that would be your basilic vein. So again, just when you're in lab, orientation is key. Like I always like to use the hand as like, okay, am I medial or lateral? Thumb side being lateral, pinky side being medial. Remember, body always in an anatomical position because this will help you for your practical because they could rearrange the arm and like even if it's like supine, but they can flip the arm over. So you're actually looking at like the other side versus what you expected. So always have that landmark, be like, okay, like radial side, ulnar side, am I lateral, am I medial? Because this will really help with orientation and just like in general, making sure you get questions right. So yeah, that's pretty much it with the venous system. And then you get the superficial venous pulmonar arch coming down here on your hand as well. That's really the biggest thing with the veins. So cool. Okay, next question. They want us to distinguish the different divisions of the brachial plexus while surrounding the axillary artery, right? They can. So when they do it though, like it will be like in relationship and in organization of what you would expect. So they could show that M and totally tag like the ulnar nerve up there. They could tag the axillary artery still, only because it is like such an important relationship and it is very similar in every body where you see that M shape. So they definitely could tag various things on the brachial plexus from that. Okay, whenever you're ready, feel free to drop your answer in the chat or on mute. Yep. Yeah, you guys got it. So it's B, it's your deltoid and teres minor. So remember abduction of your arm from 15 to 90 is going to be your deltoid. Supraspinatus does it from 0 to 15 degrees, and then from 90 up is trapezius, and then serratus anterior can help with a little bit over 100, but typically it's trapezius is the bigger worker there. And then teres minor, just remember it does adduction and externally rotation. So that, and then teres minor is also part of your rotator cuff. So remember those rotator cuff muscles are supraspinatus, infraspinatus, teres minor, and subscapularis. All of supraspinatus, teres minor, and infraspinatus will insert on the greater tubercle of the humerus and help with that external rotation versus subscapularis will insert on the lesser tubercle of the humerus and it's going to do internal rotation. So yeah, deltoid and teres minor. Any questions on this one? Major also does some external rotation, but it's not considered a rotator cuff muscle. Um, so yeah. And then remember your deltoid, that's innervated by your axillary nerve. teres minor also is your axillary nerve. Teres major is dorsal scapular. Serratus anterior for above 100. And then supraspinatus and infraspinatus is your suprascapular nerve. Okay. Kind of gave this away, but next question. And then major also can help with adduction and extension of the humerus as well. Okay, and feel free to drop your answer in the chat. Yep, axillary nerve. So I did give it away on the last one because I forgot I wrote this question. Remember that radial nerve, that's going to do all of your extensors. So thinking triceps, all of your extensors in your forearm. It's then going to go down to your hand, and on the dorsum, it's going to do the first 3.5 fingers below the nail bed. Then you have the musculocutaneous nerve. That's going to do those flexors. So thinking biceps, coracobrachialis, it's going to pierce that coracobrachialis. And then musculocutaneous nerve will terminate as the lateral cutaneous nerve of the forearm. So it becomes purely sensory. Ulnar nerve, that's going to run most medially. So it's going to run on your ulnar side. It's going to do a lot of the muscles in your hand, on towards your last 3.5 fingers, on your hypothenar, so your pinky side. And then it's going to do sensation of your hand on 2.5 digits on both your palmar and dorsum side of the hand. Okay. All right, next question. Okay, feel free to drop your answer in the chat. Yep, awesome. You guys got it. So yeah, your axillary nerve, it's going to be your surgical neck of the humerus. Okay, and you can see that really well here. So that axillary nerve, posterior circumflex humeral artery. Remember, they're going to run in that quadrangular space together. Axillary nerve does deltoid and teres minor. And then you can just see what's coming off the axillary artery. You can see that brachial plexus again. So you can kind of see this M that's forming. So ulnar nerve, remember, most medial. Median nerve is going to be in the middle of the M. And then you're going to have musculocutaneous, which is going to be the lateral portion of the M. And then the radial and axillary nerve, like you'll find underneath. So you can't see the radial nerve in this pictorial, but you can see that axillary nerve, how it's kind of coming up a little bit above and it's kind of below that axillary artery. Okay, and now I want to do some identification. So this one here on the left, what you can type it in the chat, but what fracture is this and what nerve would be affected? Yeah, awesome, guys. Yeah, this is a mid-shaft fracture, and that's going to typically affect your radial nerve. So remember, always think about what is our radial nerve supplying. We know it's going to be all of our extensors. So we would expect if we had an injury of our radial nerve that our extensors would be affected. Great. And then what about this one here on the right? Anyone else? Okay. So this one's tricky. This is a supracondylar fracture, so that's going to affect your median nerve. So when we think of supracondylar, it's going to be above these like condyles of the humerus. And so it's kind of breaking off right up there. It's not lateral, on that one. It's more medial. So I know it looks tricky from the way this is orientation wise, but this is the olecranon here of your ulna, and this is your radius. So the way this is fitting in here of what's fractured, this would be medial because it would technically be going in like this, and your ulna is more medial versus if it was like a lateral supracondylar fracture, it would have to be like closer over here where this radius is. Does that help? Yeah. So I know this is like a tricky orientation, and that's why I wanted to use this image, but also like use like your own arm too and kind of like put it in that like flexed. Yeah, I know. It's tricky, but this is your olecranon. So ulna, remember, is always more medial. Radius is your more lateral bone, and so you're supracondylar. So when I say that, it's this bottom portion, basically of your humerus. And so this is your medial supracondylar, and that's what's fractured in this image, and that would affect your median nerve. Yeah. So here. This is that supracondylar area. So yeah. And then the one that's more medial. So this is the rib cage. So this would be medial, and then this would be lateral. So yeah, that was tricky. It's more of an orientation thing, but you don't really see lateral epicondyle fractures. And you wouldn't be tested on it just because I don't think it's in your notes anywhere. So really this one's the medial supracondylar ridge here, and that's going to affect that median nerve. And then just for completeness sake, when we think of what's going to attach to like our medial epicondyles, it's going to be all of your flexors. So when you think of golfer's elbow, they're attaching there. And then your lateral epicondyle, that's where your extensors touch, and that's known as tennis elbows. Just fun tidbits to throw in there. Okay. Anything on the left there? Yeah, good job. Yep, I was just showing it again. That's your surgical neck axillary nerve. Yep. And then what about this one on the right? Hmm. And what nerve? Yeah. So it's ulnar nerve. Yep. So medial epicondyle. So here for orientation of medial versus lateral, this is your olecranon, which is going into the humerus. It's that like big head looking thing. I don't have a better way to describe it. It's just what I think of, the little head on the bone. And so you can see that attaching in. So I know this is my ulna, which means this is my medial epicondyle. And then this is my radius since it doesn't have that weird part of the bone. And so if my medial epicondyle is fractured, then I'm going to affect my ulnar nerve. So kind of just to summarize these x-rays that we looked at is if it's a shaft fracture, it's going to be my radial nerve. So when I see like a humeral shaft fracture, it's basically going to kind of be right in the middle. It's really cracking the two bones in half. It's going to affect anything like really innervated by radial nerve. So remember extensors, that posterior part of your arm. Then when you're looking at this one, it's a supracondylar fracture. I always think these ones too always look the most fuzzy in my opinion, where like you can see this is the olecranon, so that was the head I was talking about. And this is like that supracondylar ridge up here. So it's above the condyles, so kind of like up here. And so this is going to affect my median nerve. So remember, we think of pretty much all of our flexors in the forearm. Median nerve does sensation of the finger beds on the dorsum at 3.5 fingers. It also does the palmar surface 3.5 fingers. And I'll show an image of that sensation as well. But just to explain it to you. So that's supracondylar median nerve. Surgical neck, it's really up here, so it's relatively close to the head of the humerus. That's going to affect the axillary nerve. So you're going to see that teres minor and deltoid really affected, which was the example I used in the questions. And then here is going to be that medial epicondyle. So like this one, it's like a really nice like fracture right through here. Medial, remember, olecranon, medial. So this is my medial epicondyle. And that's where a lot of my flexors insert for. And then if you have inflammation of that, you get what's called the golfer's elbow. So remember all your flexors come into here. So just to give you examples, that would be like flexor carpi radialis, pronator teres, palmaris longus, flexor carpi ulnaris. And then if you were to have a tennis elbow, it would come attach here on your lateral epicondyle, and that would affect like extensor carpi radialis, extensor carpi ulnaris, so all of those, and that would be your tennis elbow. So lateral supracondylar fracture, we don't like associate it with anything from my knowledge, unfortunately. And I think it's more overall like super, yeah, cool. Okay, another question for you, which we kind of went over a lot, so I think you guys will get this pretty quickly. So feel free to drop it in the chat. Mhm. Yeah, awesome. I can't reiterate this enough. Like any spaces are always so important, really good landmarks whenever you're stuck in lab. The pentagon space is not a space, but you have a triangular space, quadrangular space, and your triangular interval. I know Pilates class is dangerous. Always remember grippy socks, but I did not fall, but I've gotten close. Okay, so when we think of a bunch of spaces and we can break it up of what this kind of looks like. So you have your triangular interval, you have a quadrangular space, and a triangular space. And so this is your scapula here. So supraspinatus, this is inferior down here. This is your humerus. So this is going to be your lateral, and this is going to be medial here. And so when we think of our quadrangular space, it's bordered by teres minor superiorly, teres major inferiorly, long head of the biceps medially, and your humerus laterally. You're going to find this is your axillary nerve, and then your posterior circumflex artery, humeral artery, and then also probably the vein running in there as well, but we don't really care about the vein for it as much as we do the artery. And this is going to be more lateral. So it makes this square here. And then you're gonna have the triangular space, which you're gonna find more medially. And so it's gonna have your teres major inferiorly, your teres minor superiorly, and then laterally being your long head of the triceps, kind of splitting it here. And so that's this space. And the artery that's running in here is your posterior, your circumflex scapular artery. So this is circumflex scapular artery. And this is medial compared to the quadrangular space. Then you have this triangular interval. So it's bounded superiorly by teres major, and then it's going to be medially the long head of the triceps, and then laterally it's going to be the lateral head of the tricep. So remember, triceps brachii means we have three of them. It's long, lateral, and medial. So the medial triceps is going to be kind of deep to the long and lateral head, but the lateral head will be most lateral, given that it's lateral. And then you have the long head of the triceps. And so what you would find in this triangular interval is your radial nerve and your profunda brachii artery. And so remember that profunda brachii artery is what's coming off of the brachial artery. And these two are going to be best friends. They're going to run together and kind of supply everything in the back of the arm. Any questions on those spaces? Or borders or anything? Okay. And then I kind of just laid it out here again for you. So quadrangular space, remember that's going to be our one most laterally. It's going to be between teres minor, teres major, long head, and humerus. You're going to find the axillary nerve, posterior circumflex humeral artery. And then I kind of gave where that artery goes. So it does a bunch. Deltoids, teres major and minor, long and lateral head of the triceps, it can help out with. And then that triangular space, which is going to be more medial between teres minor, major, and long head of the triceps. And so you're going to have the circumflex scapular artery, which will help with the deltoid, teres major and minor. Remember, it's a part of that scapular anastomoses as well, because it's circumflex, meaning that it's literally going to kind of wrap around like the scapula. And that's important in that scapular anastomoses, because we always want to make sure we have blood supply. And then the triangular interval. So it's going to be between the long and lateral head of the triceps, and then teres major above. And remember, we're going to find the radial nerve and then the profunda brachii artery. Okay. Next question. Yeah, you guys can drop your answers in the chat. Okay, most of you guys are getting it. So yeah, it's radial nerve. Yep, it's your Saturday's night palsy. So if your radial nerve can get irritated, like if people are in crutches or if like someone passes out in a kitchen chair with their arm kind of like hung over it and it's impinging on like in that axilla area. So radial nerve, remember, so he's going to have trouble with extending his fingers. He's going to have difficulty grasping objects, and he's going to lose sensation on the dorsum of the first 3.5 fingers prior to the nail bed. So that's all radial nerve. Remember, median nerve will do, it's going to be associated with flexion. It's going to be associated with those thenar muscles, carpal tunnel syndromes associated with median nerve. You can also have like difficulty grasping objects too, but you would see issues more with like your thumb, which is really what your median nerve does. And then in terms of sensation, you would lose on the dorsum 3.5 fingers of the nail bed, because remember, radial nerve goes up until the nail bed. And then on the palmar surface, that's going to be 3.5 for the median nerve. Axillary nerve we talked about, but that's going to be difficulty with initiating, it's going to be difficulty with abduction from 15 to 90, so a little bit of difficulty with external rotation and adduction because of teres minor. Anterior interosseous nerve just comes off of median nerve. And then musculocutaneous nerve, you would have some trouble with some of like your flexion with your biceps and things like that. I saw someone in the chat put in claw hand. So with radial nerve, it's not really a claw hand. You see more of a claw hand with ulnar nerve and median nerve because radial nerve does not supply really any of the muscles of like the hand itself. It's typically like if you're thinking of thenar eminence. Yeah. Okay, cool. But no, you're fine. Just to kind of explain it for everyone. But when you think of like a claw hand or something like that, you're gonna affect more. Either it's gonna be your median nerve, so something with like carpal tunnel or various things. You can have like the hand of benediction, just depending on where the median nerve injury is. And then you can also have like a claw hand with an ulnar nerve as well. And a lot of that's seen with like cyclers with when the ulnar nerve passes through what's called like Gouon's canal, like going into the hand. And the ulnar nerve does a lot of like your lumbricals, it does your dorsal and palmar, like interosseous muscles, it does all like your hypothenar, so all like your pinky muscles. So that's where you can kind of see that like claw hand with that. And then, yeah, here's just a really nice picture of it with the radial nerve. So it's going to be deeper under that initial M, does all of your extensor muscles. So it does extension of the wrist and fingers because it'll do like with the fingers, when I say going into the hand, it does this, the fingers, because of extensor digitorum. So it has tendons that attach to all the fingers. And then when I mean like the hand intrinsic, more muscles itself that really start in the hand and end in the hand, that's going to be the median and ulnar nerve, which if you haven't gotten to this week, you'll get to next week. So you might have no idea what I'm talking about, but you will at least have an idea of it when you do. Remember, it does the tricep, so that extends the elbow. And then, yeah, if the muscles are not working properly, the patient will have wrist drop. So think about it, this is flexion. So if they can't extend, what's going to happen is they're only going to be able to flex. And so that's why it's called wrist drop. So anytime you think of like muscle injury, if you knock out the function of a muscle, you're gonna get what the opposite is. So in this case, like if you know radial nerve does extension and you can't extend, well, the only thing you can do is flex. So that's another way of thinking about injuries and things like that. Okay. Next question. Okay, feel free, drop it in the chat. Yeah, awesome job. So this is one of those things where I kind of wanted to trick you guys, but you guys got it. So whenever the most important thing is weakness versus loss of muscle function, and a loss of muscle function means like this muscle is the only muscle that can perform this action. So if you have damage to the nerve or artery, you will not be able to perform it. Versus a weakness is, yes, like you might knock out the primary muscle of doing an action, but another muscle has the function of doing it. So you still retain a little bit of function, even if it's not the best. So in this case, we already distinguished that it's a radial nerve injury. And so one of the biggest muscles of supination is the supinator itself, which is innervated by the radial nerve. So we know we knocked out the supinator, and that's a super important muscle. So what is a muscle that allows him to keep his function of supination? And it's biceps brachii. So even though it's a big flexor of the elbow, we also know that it actually carries a little bit of ability of to do supination. And this is innervated by musculocutaneous nerve. So its function of supination is not even going to be affected at all. So that's why Brad would have a weakness in supination. Pronator teres, it does the opposite. You would be doing pronation. Coracobrachialis, that's a flexor. And then triceps brachii is an extensor of the elbow. So does that make sense on weakness versus loss of function? Perfect. And then kind of just to show you what the bunch of muscles look like. So olecranon we know is associated with the ulna. Here we're looking at our extensor surface, so everything kind of with the radial nerve. So brachioradialis, your extensor carpi radialis longus, you have a brevis, extensor digitorum, extensor carpi ulnaris, extensor digiti minimi, and it's originating from the lateral epicondyle. So that would be the tennis elbow. So kind of some of these come and then they wrap around this way, like your extensor carpi ulnaris, because you're like, okay, if you're telling me ulnar's medial side, why is it coming from the lateral epicondyle? It does, but it crosses over and then it'll insert on the ulnar side. So it tells you where it's going. Okay. And then I can't reiterate this enough. Like, there's so many of these pictures out here. I feel like this one's one of the more simpler ones, but really know the sensation, because in a lot of questions, like they might give you just like the muscle issues, but they can also include the sensation. And I feel like this was such a great way for me to be able to like check my answer and like be confident in that answer choice. So remember, this is the dorsum of the hand. This is the palmar surface of the hand. And so from the dorsal surface, remember that radial nerve will do the first 3.5 up before the nail bed. So nail beds being like where the nail is. And then your median nerve will do the actual nail beds on those fingers. And then your last 3.5 is going to be your ulnar nerve. And then remember, ulnar and median kind of split this fourth finger here between that. And then when you're looking at the palmar surface, so kind of in that lower thumb area, you do get a little radial nerve there. So keep that in mind. And then your median nerve will do the 3.5, 3.5 digits. And then your ulnar nerve will do the last like 1.5 here. Okay. That is my slideshow for you guys tonight. Does you guys have any questions at all?